Welcome back, listeners. Thanks for tuning in again to Let's Talk Patient Blood Management. I'm Marianne, and I'm here with Sarah. Hi, Sarah.
Hi.
We have another great guest today. I'm so thrilled and honored that we have Dr. Faraoni with us here today. Sarah, why don't you tell us a little bit about our guest today?
All right. I'm so happy to introduce David Faraoni. He is a pediatric cardiac anesthesiologist, and he's originally from Belgium. He has had the opportunity to work at Boston's Children's Hospital and at Harvard Medical School and the Hospital for Sick Children at the University of Toronto, Canada. Since 2021, he has been a pediatric, adult, and congenital cardiac anesthesiologist within the Arthur S. Keats Division of the Pediatric Cardiovascular Anesthesia, Perioperative, and Pain Medicine. And at Texas Children's Hospital, you're also a professor of anesthesiology at the Baylor College of Medicine. Is that correct, Dr. Faraoni?
That's correct, Sarah. Thank you. Thank you so much for the very kind introduction. And Mary and Sarah, thank you for having me on this podcast. Great to be here with you. You've done a great job with the podcast, so I'm really excited to get a chance to talk to you about patient blood management today.
Oh, thank you for your kind words, and I'm grateful to have you here as well. Dr. Faraoni, let's get right into it. How did you get interested in patient blood management?
So I started pretty early when I started my residency in anesthesiology back in Brussels, Belgium, when my program director and my mentor and my PhD director was actually Professor van der Linden, who was at that time the president of NATA. And his research was on red blood cells transfusion, hemodilution, anemia. And so it was a really easy path for me to get into and start doing research in transfusion with him. And pretty early, and when I realized that my pathway would be into pediatric anesthesia and pediatric cardiac anesthesia, it was a very easy choice to kind of translate the research that we were doing into the pediatric population. So that was really when I started, and at that time I say we were more talking about blood conservation than we were talking about patient blood management. But over the years, obviously, the topic of patient blood management and the definition of patient blood management became a little bit more known, and so it's really the field that I've been working on for, I guess, now a decade.
And David, I know what you have told me and some of your colleagues is that pediatric patient blood management is not the same as adult patient blood management. And so can you kind of tell us a little bit of difference and the gaps in the literature that we have today?
Yeah, and I think this is a very important concept that I think many of the pediatric physicians involved in blood management have kind of tried to highlight over the years, that we don't deal with small adults. We deal with a very different population in so many different aspects. And even though the concept of patient blood management and the pillars are the same, and we're talking about the same type of strategies, I think we cannot extrapolate everything that the adults have done into the pediatric patients because of the obvious differences between the population. And when it comes to the challenges that we pediatric physicians have faced with the development of patient blood management, and the fact that we are so far behind, as you said, with the data is I think for several reasons. One is a good reason, actually, is we talking about an extremely small populations. We have a lot of children, but many of the children are healthy and are not requiring our care, which is a very good thing. So the subset of patients that we do see, and the subset of patients that are extremely sick or sick enough to require surgery and complex surgical procedures, is a very small number. So when it comes to collecting the data, getting the research done, but we're talking about a small population that is hard to find, even in a big institution like Texas Children's, for example, or Boston Children's. The second challenge is the fact that when you have small numbers, it takes a lot of time to get quality data. And as you know, the field is changing over and over. So you can't really afford to have a study that would need 10 years to be completed, because who knows where we will be in 10 years from now.
Mm-hmm.
The third aspect is I think emotional. As we I'm sure we all understand, is very different to recruit a pediatric patient in a study than you would recruit an adult, because of the emotional aspect for the parents to really want the best care for their children. And research sometimes bring this uncertainty on what type of therapy is he going to get, or is she going to get. Why are we taking extra blood samples to my baby that is so tiny, and we want to you telling me you want to conserve the blood, but at the same time you want to take some blood from him. So there's a lot of emotions that comes into the recruitment of patients in studies, which makes it extremely hard for us researchers and physicians and nurses to recruit patients in studies.
I can see that because being sick, like if I was sick myself and someone said, "Do you want to join a study in advanced medicine?" I'd be like, "Yeah." But if it was my child, I would be way more hesitant.
I know it's a very different. I've as I said, I've been doing that for 10 years, and I don't want to get too personal here, but as you know, I recently had a little baby, and who was in NICU for a little bit. And for the first 48 hours, we saw probably 3 or 4 teams coming to us and asking us, "Hey, do you want to be part of the study? We're going to take some blood samples." Even as a scientist, it took me some time to kind of think about it and be like, "Whoa, really? Do are we going to do that?" So it's extremely emotional, I think, when it comes to babies and children.
Absolutely. Yeah. And that was a great example. Thank you so much for sharing that with us. You talked about, we hear this once in a while about how we used to do blood conservation, and now the concept has changed a little more to patient blood management. And I think that is really clear here in what you said about they're not just little adults, they're not just smaller, we don't just give them a little less iron or whatever. It's really patient focused, patient blood management. So, how about like when, as far as signs or even numbers, like what are the numbers for children? Are they the same numbers, like you're anemic if you're 12 or 13, or is that different? How do we identify that?
Yeah, that's a very good question, because so the way the definition of anemia works for children is actually based on a WHO definition, which took a large sample of pediatric patients and decided that the anemia level will be 2 standard deviation below the mean. And if you look at their charts online, that if you look at anemia pediatrics and WHO online, you will find a table that is pretty much used everywhere. And you'll see that the definition is somewhat subjective, because it changes over time. It changes depending on certain factors. But in addition to age, there are other factors that you have to take into account. And for example, we know that the prevalence of anemia is extremely high in patients that are 6 months of age, for example, which is pretty much a physiologic anemia coming from the decrease in their newborn hemoglobin. And then at that time, they're supposed to start producing a lot. But as you know, producing a lot means that you need to have iron. And at that time, babies are fed either with formula or with breast milk. And the breast milk is not containing iron. Formulas are different, and I don't know if parents realize that is not all formulas are equal. So if you feed your baby with formula, there's different levels of vitamins, there's different levels of iron in there, which means that you may need to supplement your baby with iron. And it's something that I think is probably known if you have a pediatrician that is aware and that is active and sees you regularly. But again, if you have a very healthy baby and that doesn't see the pediatrician that often, sometimes it's something that is forgotten. And believe it, as a pediatric anesthesiologist, if we see patients coming with around 6 months of age for surgery, I can tell you that the majority have some degree of iron deficiency anemia.
So, are you saying that there's a connection between maternal anemia, pregnancy anemia, and childhood, like infant anemia?
Right. So there is a clear relationship between having a mom who is iron deficient anemic during pregnancy and the newborn being iron deficient too, because obviously everything the newborn has is coming from his mom. So there is a clear relationship there. So one of the risk factor for anemia is prematurity, for example, because then the baby is born too early and therefore doesn't have the time to get his storage up. And number two is having patients born with mothers who were iron deficient anemic because they didn't store enough of iron for the baby. So those are really important factors, which goes back to obstetrics and the importance of iron deficiency anemia in the obstetric population, for example, which is something that is not always known either. I don't know what's the percentage of pregnant women who are taking iron supplements, but it's something that is important.
So we know that there's a gap, and we know that it's hard to find, research subjects because of kind of the ethical. But in your mind, why is it important that we catch up on the gap?
Well, it's important because I think, as I said, thankfully many of the pediatric patients are healthy and don't have issues requiring hospitalization or surgical procedures. But that doesn't mean that you have to leave them out there with iron deficient anemia, because eventually they will go to sport, they will go to school, they will start running around, and then they get fatigue, and then that has an impact on their quality of life, I would say. So
Mhm.
it's important to make people understand that this is an important aspect of the care, and that this is something that needs to be considered. I think we one of the challenge maybe is the fact that when you think about anemia, for you and I here on this podcast, it's clear that, for example, transfusion is somewhat of an endpoint, right? So if we go for surgery and we anemic, well, we might end up being transfused, and we might end up, having a slower recovery and things like that. But if you don't see the end point, sometimes for the parents, I don't think it's really clear why they should give their child iron. Even more so that, as I don't know if you guys have taken iron before, but I remember taking iron when I was younger, and it's not nice. It's not easy.
Mm.
It's something that hurt your stomach. You have pain for a little bit, and so it's easy for the parents to give up on the iron option because they don't see really what the endpoint is, and they also see that the baby, their child, is not tolerating it very well. So those
Mhm.
are important, I think, consideration when it comes to treating anemia in children.
Absolutely. And you made a good point about, these kids, they're out there and they're napping all the time, or they're not, or they're running around all the time and they're not. And we kind of maybe overlook those obvious to us signs that, they're maybe tired or unmotivated or apathetic or what have you. And we just kind of overlook that maybe they're anemic, so we really have to hone in on that. And sometimes people say, oh well, they're just a little anemic, it doesn't really matter. But we need to help parents understand that there's long-term consequences of anemia in children. Is that right?
Yeah, there are I think the most important is you have to start right and early. And as I said, the 6 months of age is a key because it's where we know there's a physiologic anemia anyway. So if you can decrease the dip as much as you can, and if you can provide the babies with enough storage, but then you might be able to change the course of their hemoglobin rebound in the next months and years. The next important stage, which is puberty, and especially essentially in female, where where they start to have their first periods, and then they start losing blood, and then there's a second a little bit dip there with anemia. But it's important to start early, because any child at 6 months of age would have some degree of anemia and some degree of iron deficiency. So it's really the time where you have to take that into account, keep that in mind, and your pediatricians hopefully can help guide the parents in treating that.
I think a big thing when I heard that iron deficiency in pregnancy can affect the cognitive development of the growing fetus. Do you know if that's the same with growing infant or child? If so, is the cognitive, I guess, dysfunction, is it corrected when the anemia is corrected? Or is it kind of a permanent developmental loss if their iron deficiency wasn't handled?
I think it's a good and a difficult question, because a lot of those things, when it comes to association between something that happened during pregnancy and something that happened in the child, is difficult to relate as a one-to-one, so a causation between the two, because there are so many factors. What we do know is it has an impact. What is the impact, and what is the impact if you treat the mom and if you treat the baby? It's hard to know, because the cohorts that we have when it comes to looking at big size cohort like that, there's so many factors. And to give
Mm.
you a simple example, there might be, for example, socioeconomic association too, right? So
Mm.
the likelihood that, you know, a mom living in a nice area in a nice city and has access to care will be treated with iron is higher than if you
Mm.
have somebody in the more, challenging socioeconomic space, where they might not have access to a physician. They might not see their physician until delivery, and
Mm.
therefore, in this case, you see, yeah, she comes anemic, and there is an association, but would treating makes the difference that we hope it will make? Probably, but it's hard to, again, going back to research, it's hard to show unless you have a prospective randomized study where you randomize patient between a treatment and not,
Mhm.
which, again, going back to the emotional aspect, would be challenging, because if you come and tell me there's a potential risk that there will be an impact on your child if we don't treat you, but let's randomize you, I
Right.
think it will be harder to accept, right?
Definitely.
Can you quantify? I think I've heard, and I don't know if I'm correct or not, but that maybe 20% of children are anemic. I don't know if that's true or not.
Yeah, that sounds about right. I think the prevalence, if you take worldwide, and again, if you go on the website, on the WHO website, you'll see really international data. The average prevalence is about 20-25%. However, at certain age, it goes up to 40%, and in some regions of the world, it goes up to 60%. So
Wow.
it's a very significant problem. It's a very prevalent issue, and even more so in some regions of the world where the prevalence is extremely high, and they might not have access to all the resources that we have.
Another thing I've noticed in my practice as an RN is that when an adult doesn't like the oral, or maybe they have tummy upset or whatever, we move right into IV iron. But that's not necessarily the case. We don't see IV iron given as much in the peds population, and I'm wondering why that is.
Yeah, and this is also a very important point. And if you've been to Sabam, and you may have heard me say that a few times, the issue is, if you think about the big picture, you will hear a lot of people involved in patient blood management telling you oral iron is not working that well. You have to go for IV iron, especially in an acute or subacute setting of surgical procedures where you're trying to optimize your patient before a certain procedure. And I've said that many times. For us, it's extremely hard to do that because, again, with the emotional aspect of, if I have a 6 month old coming for a surgery, it's already emotional. And on top of that, you're asking the parents to bring the kid to the hospital to get an IV. He's not going to like it. It's going to cry. And then you have to keep the patient still for an hour when he's getting his iron. And then you have to monitor the patient for a little bit. And if you ask the parents to do that 1, 2, 3 times before, let's say, spine surgery or craniofacial surgery, it becomes really challenging. And in my experience, we decided to take maybe less optimal way on an iron therapy perspective, but more effective way on a system level. So we decided to go with oral iron. So if the baby, the children's are eating fine and they don't have any GI issues, we'll go for oral iron, and we'll give them some time. We'll give them some time to see how they respond to the oral iron. And I would say it's not a guarantee for one, because some patients don't absorb well, some patients don't, don't really respond well to oral iron, and then there's also some parents just give up, and they sometimes tell you, sometimes don't tell you, um, and we monitor them, and then we decide if we satisfied with the response or not. And if we're not satisfied, one of the things that we try to do is to bring the patients for an IV iron infusion before an important surgery. And we've had some success. We've had some success in patients that are very sick, for example, the patients with heart failure, because in that context, I think it's easier for the parents to understand. Well, we have to do everything for this our baby to recover from the heart failure.
Mhm.
So again, giving you an example of, on the emotional balance, where do you put, risk benefit again,
Mhm.
um, and um, and so we've had some successes with that. And one thing that I advocate more and more, which is very difficult, if believe me or not, to get a support even from the PBM community, is to say, even if you don't catch the patient anemic before surgery, don't let them go home anemic, and don't let them go
Yes.
home iron deficient. And we see that
Yes.
here, for example, in my cardiac program, where we're not very good at catching them, because we are a big referral program. We see patients from all over the country. We don't really see them ahead of time. So sometimes we have a 6 months old coming for a VSD repair that is anemic and iron deficient.
Mhm.
But one thing that I really try to advocate is, it's not too late to do it right. And you have the patient right in front of you for at least 5 to 7 days. So
Right.
don't let them just sit there and go home with iron deficient. There's no reason for that.
Absolutely. I feel like that parents understand, oh, your child has a low blood count. We'd like to give them a blood transfusion. But they don't really understand, oh, your child has low iron and a low blood count. We'd like to give them iron. Can you kind of talk to parents a little bit about maybe the risks and benefits of choosing to go the route of, correcting the anemia through a blood transfusion versus giving them iron?
Yeah, and I think that's the importance of what you guys are doing, for example, and what societies like SAVM and NATA and others have done is, there is a concept in the population that, I mean, transfusion is safe, right? Like, there's no problem with transfusions. It's coming from the blood bank. It's been checked. There's no risk of infections anymore. People don't die from transfusion anymore. Therefore, that's the easy answer, right? And I think the issue I find personally is, there's only a small proportion of us in healthcare that are actually advocating for the best quality of care that is not a first line transfusion, right? So I'm sure you guys see the same thing than me.
Mm-hmm.
I have surgeons here who think like, why do you want to come 2 weeks before, 3 weeks before? Just we'll give you a good old blood transfusion and you'll be fine, right?
Mm-hmm.
And so there's a it takes a lot, because it's you have to convince patients and parents, and for sure, but you also have to convince colleagues sometimes, so oftentimes, and
Mm-hmm.
institutions that if there's a way of doing it without transfusion, but why not? Like, it's like if I was saying to the parents, oh, we're not going to fix your VSD, we're going to transplant you with a new heart, right? We
Right.
don't go that way. Like, we know that this is not the way to go. And it's I'm sure many of you have heard the fact that transfusion is a transplant to some extent. it's
Hmm.
it's in it's blood from a donor coming into somebody else's blood, and there are reactions and there are risk of side effects, and we have to minimize them as much as we can.
Especially in a child who is in such a situation that they would need a surgery or a transfusion for some reason. Yeah, you want to take all the routes that are the most safe as possible.
Yeah, that's why I really like the fact that you advocate for, you may not have been able to work them before, but let's not send them home deficient. That's really great. What's your relationship like with the pediatric on hematology group? Do you work well together? Do you agree on the patient blood management concept or approach, or how does that work in your facility?
So at Texas Children's, we are pretty lucky because we have a very good relationship with hematology and the anemia clinic. I was lucky to come in a system that was already working on iron deficiency anemia in heart failure patients. So they had the system
Mm,
in place. They understand the importance in that specific population. And so my job was kind of like to be like, well, why don't you expand that outside the heart failure patient? Because many patients are anemic. So I say the relationship is great. They're very receptive. They're very good at seeing the patients when we ask them to. And the iron clinic is very well functional on a pediatric level. I think the challenge is that we still have, and I'm sure many of people listening to this podcast will share, is the challenge of making physicians understanding that this is important and that they should refer more patients to the clinic. It's a work in progress.
mhm.
I think we've done some progress in at least in the cardiac patients, for sure in patients that are declining blood transfusions, but we are far from having a system-wide patient blood management program.
Okay.
My experience at other institutions was sometimes different, especially in places where there was not really a concept of patient blood management. But but here, and I think in many now pediatric institutions, we're lucky to have advocates for patient blood management, like Dr. Gooby at Boston Children, Dr. Downey in Atlanta, or Dr. Esler at Columbia University. And there's a lot of people in the pediatric community working on patient blood management.
Yeah, the culture change is such a challenge, definitely.
Any research that you're excited about that's going on right now in the realm of pediatrics and patient blood management?
Yeah, I think we have, and some of it was supported by SABM, for example. We have a few studies that are now looking at actual number and actual prevalence of iron deficiency anemia. For example, in spine patients, you may remember Lisa Eisler 2 years ago from Colombia. Last year, also the awardee from the SABM award was a pediatric physician. So the last two SABM awards were actually given to pediatric anemia research, which I think is really good. There's a lot of initiatives. We have a lot of committees that are forming around the country, and international groups as well. The Society of Pediatric Anesthesia has a patient blood management group now. The Cardiac Society has a patient blood management group, even though it's still called hemostasis group, but they deal with a lot of patient blood management. So and those groups are usually well filled by the players in the pediatric field. So I suspect one of the big improvement that we will see in the coming years is probably a better assessment of anemia, a better understanding of the prevalence, and hopefully a better option for therapies. That's going to be the challenge, like it was in adults and probably is still in adults.
Mm-hmm.
But those are, I think, the most exciting component when it comes to anemia.
This has been such an excellent conversation, very enlightening, and we thank you so much for sharing your knowledge with us. Any takeaways that you'd like for parents to know, or listeners to know, or physicians to know? Anything you'd like for our folks to take away?
Yeah, I think I hope that people understand that pediatric patient blood management is important, and that we need support, and that we need resources to be successful at that, because as you said, and as we said when we started, we are far behind. It's a small population, but it's a very important population. So I'm really happy that even Sabam, for example, has done a great job at giving us a chance to have a voice and to give talks and be part of webinars, and you have been giving me a great chance today to be with you and
Mm.
talk about pediatric patient blood management. So thank you for that.
It's been our pleasure. I've enjoyed working with you in the past. I hope that I
Likewise.
get to work with you in the future down at Baylor and help you guys implement more PBM in Texas. I
Absolutely.
would love to come down and help you guys with that. So
Anytime. Thank
Thank
you.
you.
Thank you. And keep up the good work.
We hope you enjoyed this conversation and found some takeaway or new thought that improves your health. We would love to hear from you. Feel free to reach out to us on our website if you'd like to see what we're up to. Our website is letstalkpbm.com. If you enjoy our conversations, please like and subscribe wherever you listen to podcasts and on our YouTube channel.
special thanks to our guest and our producer Delaney Coronado and the entire production team for all of their expertise in content creation, technical abilities, and dedication to our message. We appreciate the experts who drive this medical movement forward, and our affiliate partnerships who support the work that we are doing. Until next time, stay connected to your blood health.